Okay, great. I hope everyone can hear me. And it is a pleasure to be here this morning. I am coming to you from Florida. And just as a quick note, the Center for Healthcare Delivery Science does have offices that are in Jacksonville and Orlando, as well as the offices that are in the Delaware Valley. So this morning, I thought I'd talk about a project we recently were able to publish data from this project in Diabetes Care. It's in the November 2022 issue. And what we were looking at is cutoff scores and how to increase sensitivity for the cutoff scores for common depression screening tools that are used in youth with type 1 diabetes. Move my. All right. So hopefully you can see this. Just as a brief overview, diabetes, it's a fairly common chronic medical condition for youth. It is complicated. It takes a lot of time to take care of day to day. And we know that from epidemiological studies that about 1 in 7 youth who have type 1 diabetes also endorse depressive symptoms. And that's just higher than the general population rate, which is about 12%. And also, if you are a youth with type 1 diabetes and you have depression, we see that it can affect their management day to day. It can lead to higher hospitalization levels. And so because of all of these factors, since 2014, clinical care guidelines for youth with type 1 diabetes have included clinic-based depression screening. But there are some challenges to those guidelines. For example, now it won't move. There we go. These guidelines are still fairly vague. They tell us when to start screening, how often, but they don't give us any tools on which screening measures we should be using. There can be a potential overlap between symptoms of dysglycemia and depression, which can make it hard to identify youth who are truly depressed. And then there's also a lot of inconsistency published in the literature about what are the optimal cut points to use to determine if someone is depressed or not depressed. And based on the cut point that you use, that's going to impact the sensitivity or specificity of that tool. The other challenge that we have is that many of these depression screening tools include a single item suicide risk assessment. So for example, the PHQ-9, which is the form we use here at Nemours, includes item 9, thoughts that I would be better off dead or hurting myself in some way. There's also the CDI-2, which includes item 8, and that the youth would endorse one of those. I do not think about killing myself. I think about killing myself, but would not do it, or I want to kill myself. We haven't looked at how they perform in youth with type 1 diabetes, but we know based on general data from the general population that these single item suicide screening measures have fairly low sensitivity at 0.7. This would suggest that we could miss people who have actual suicide risk or suicide ideation if we just apply these single item suicide screeners. So our study aims, we were interested in looking at diagnostic accuracy and optimal cutoff scores for common depression screening tools for youth with type 1 diabetes. And then as a secondary aim, we wanted to look at the accuracy and optimal cut points for those commonly used single item suicide risk items. Our study was cross-sectional. We had youth that we recruited. They came in and they completed a battery of different suicide screening tools. These are all depression screening tools that are commonly used in the United States, and we had them, youth filled them out in a random order. We also had them complete a reference standard diagnostic interview so we could identify youth who had current depressive symptoms. For the purpose of this presentation and to streamline the results, I'm just going to talk about the results we have for the Child Depression Inventory Short and the PHQ both 2 and 9, because those are the most commonly used depression screening tools in diabetes clinics in the United States. So here is our sample. We had 100 adolescents with type 1 diabetes that we recruited and completed the project. They had a mean age of about 15. They were almost equal male to female. We had a fairly good or high rate of diabetes technology use when we think about insulin pumps, CGM. And one of the things that I think is remarkable is that we had about 15% of our adolescents meet criteria for depressive disorder. So remember, epidemiological data would say about 14% would be potentially depressed, and so we were able to fairly closely approximate that even in our research sample. So our aim one was looking at accuracy of our depression measures, and first applying what are more common used cutoff scores in clinics. So if a cutoff score, for example, of 3 for the CDI-2 in our sample had perfect sensitivity, but it came at the risk of having a number of false positives, fairly poor specificity. In contrast, both the PHQ-2 and the PHQ-9 had, when we apply the commonly used cutoff scores of 10 and 3 respectively, had fairly low sensitivity. So we would miss potentially youth who are depressed. If we adjusted, though, we found that we could actually improve sensitivity and specificity. So proposing perhaps cutoff scores that are specific and unique to youth who have type 1 diabetes. So increasing the CDI-2 cutoff score to a 5 and decreasing the cut points for the PHQ could have that better balance between sensitivity and specificity. Remember, our aim 2 was looking at the accuracy of those single item suicide risk assessments, and we applied first the standard cut point, and then we also looked at what would happen if we lower those cut points. And unfortunately, what we found is that they all had fairly low sensitivity, and that there was really nothing we could do to improve that sensitivity, and that just using that as a measure for suicide risk could mean that we would potentially have youth that would go undetected. So as general conclusions and implications from this project, we would recommend that to improve detection of depressive symptoms during routine clinic screening, clinics should stop using the PHQ-2 and just either administer the PHQ-9 or the CDI-2 or one of the other measures, which I didn't talk about, but also we present on in our diabetes care manuscript. We would recommend diabetes-specific cut points, so lowering the cut point for the PHQ-9 to 5 and increasing the CDI cut point to 5. And then we would recommend not using the single-item suicide screeners at all, and instead using a separate suicide-specific screening tool, such as the ASK, to determine risk for suicidal ideation. That is my presentation. So with that, I could take questions if there are any.